Every single night, 60 million Americans go to bed with a bottle of antacids on their nightstand. Not occasionally, but every night. Sometimes twice a night. Sometimes keeping that bottle in their jacket pocket, their car, their desk drawer at work. They have been told the same thing by every doctor, every commercial, every health article they have ever read. Too much stomach acid. Take this pill. Reduce the acid. Feel better. I am going to tell you why that explanation is wrong in the overwhelming majority of cases. In 15 years of clinical practice, I have watched patients spend years, sometimes decades, suppressing stomach acid that was never the problem in the first place. The real culprit, the actual mechanical failure causing that burning sensation, that regurgitation, that chronic cough, sits 1 inch above your stomach. It is a small ring of muscle called the lower esophageal sphincter, and in 96% of reflux cases, it is not doing its job. Your next gastroenterology appointment will not include an examination of this valve. There is no billing code for teaching you how to restore its function. The system makes money when you stay on acid suppressors for life, not when you fix the mechanical problem in 3 weeks. Subscribe to Dr. Waterling right now and hit that like button. We are working toward building this channel on one principle: giving you the information that actually solves the problem, not the information that creates a lifetime customer. Here is what is actually happening inside your body right now. Your esophagus, the muscular tube connecting your throat to your stomach, ends at a precise point where it meets the top of your stomach. At that junction sits a ring of smooth muscle, roughly 3 to 4 centimeters long, that functions as a one-way valve. When you swallow, this valve relaxes, opens, allows food to pass down into your stomach, then immediately contracts shut again. The entire cycle takes less than 1 second. That valve, the lower esophageal sphincter, maintains a resting pressure of approximately 15 to 30 millimeters of mercury. Your stomach, meanwhile, generates internal pressure through digestive contractions and gas production. As long as the sphincter pressure exceeds stomach pressure, the valve stays sealed. Nothing moves backward. When the sphincter weakens, when its resting pressure drops below 10 millimeters of mercury, stomach contents push upward into the esophagus. That is reflux. Not too much acid, weak valve. The esophagus is not designed to handle acidic content. Your stomach lining produces thick mucus that protects it from hydrochloric acid. Your esophagus has no such protection. When stomach acid contacts esophageal tissue, it causes immediate chemical burning. That burning sensation you feel behind your sternum, that is not excess acid production. That is normal stomach acid in the wrong location because a weakened valve allowed it to escape. Now, why does conventional medicine ignore this mechanical reality and focus exclusively on acid suppression? Because there is a $15 billion per year global market for proton pump inhibitors and H2 blockers. These medications reduce stomach acid production by 70 to 90%. They do not strengthen the sphincter. They do not restore valve function. They simply make the fluid that is escaping less acidic. You still have reflux. You just have less burning because the fluid coming up is less corrosive. But here is what nobody tells you. Stomach acid exists for critical reasons. It activates pepsin, the enzyme that breaks down protein. It kills bacteria and parasites in your food. It enables absorption of vitamin B12, iron, calcium, magnesium, and zinc. When you suppress acid production chronically, you create systematic nutritional deficiencies. After 2 years on proton pump inhibitors, bone density measurably decreases. After 5 years, the risk of pneumonia increases by 30% because reduced stomach acid allows bacterial overgrowth that migrates to the lungs. I have seen patients on acid suppressors for 10, 15, 20 years. They come in with osteoporosis, anemia, recurrent infections, digestive dysfunction. When I review their medication history, there it is, the same prescription renewed automatically year after year. Nobody ever questioned whether the sphincter could be strengthened. Nobody offered an alternative. The pharmaceutical approach treats the symptom while ignoring the cause and creates new problems that require additional medications. Let me tell you about Margaret, 58 years old, who walked into my office after 12 years on omeprazole. She had been prescribed the medication after 3 months of heartburn following a stressful period at work. The prescription was supposed to be short-term, 3 months maximum. It turned into 12 years because every time she tried to stop, the reflux returned within days, often worse than before. That is called rebound hyperacidity. When you suppress acid production artificially, your stomach compensates by increasing the number of acid-producing cells. Stop the medication suddenly, and you get a surge of acid production that creates severe reflux even if your sphincter has recovered. Margaret also developed iron deficiency anemia, required supplementation, experienced 3 episodes of pneumonia in 2 years, and had bone density measurements showing early osteoporosis. All of this while still experiencing breakthrough reflux despite maximum dose acid suppression. The medication was not solving her problem, it was creating new ones. We stopped the proton pump inhibitor using a gradual taper protocol, implemented sphincter strengthening interventions, and addressed the factors that had weakened her valve in the first place. Within 3 weeks, her reflux episodes dropped from daily to once or twice per week. Within 2 months, she was completely symptom-free without any medication. Her iron levels normalized. Her recurrent respiratory infections stopped. Now, what weakens the lower esophageal sphincter? Several factors, most of them completely reversible. First, abdominal pressure. Anything that increases pressure in your abdomen pushes upward against the sphincter and forces it to work harder to stay closed. Obesity, particularly abdominal obesity, creates chronic elevated pressure. Tight clothing around the waist does the same thing. Lying down flat immediately after eating means gravity is not helping keep contents in the stomach, increasing the work the sphincter must do. Second, dietary factors that directly relax smooth muscle. Chocolate contains theobromine, which reduces sphincter tone. Peppermint contains menthol, which has the same effect. Alcohol relaxes smooth muscle throughout the digestive tract, including the sphincter. Coffee, both caffeinated and decaffeinated, stimulates acid production and relaxes the valve. These are not allergies or intolerances. These are direct pharmacological effects on sphincter muscle tone. Third, smoking. Nicotine reduces sphincter pressure by approximately 40% within minutes of exposure. It also reduces saliva production. Saliva contains bicarbonate, which neutralizes small amounts of acid that reflux into the lower esophagus. Reduced saliva means reduced neutralization capacity, turning minor reflux into burning symptoms. Fourth, certain medications. Calcium channel blockers used for blood pressure, benzodiazepines used for anxiety, nitrates used for heart conditions. All of these relax smooth muscle, including the esophageal sphincter. If you started experiencing reflux shortly after beginning one of these medications, the drug is the likely cause. Your doctor should have warned you. Most do not, because they assume you will just take an acid suppressor to manage the side effect. Fifth, hiatal hernia. The esophagus passes through an opening in the diaphragm called the esophageal hiatus before connecting to the stomach. In some people, the upper portion of the stomach pushes upward through this opening, creating a hiatal hernia. This anatomical displacement disrupts the sphincter's ability to maintain pressure. Small hiatal hernias, under 2 centimeters, often respond to postural changes and exercises. Large hernias may require surgical correction, but that is a small minority of cases. Here is your complete protocol for restoring lower esophageal sphincter function, organized by category. These are not vague suggestions. These are specific interventions with measurable effects on sphincter pressure. Postural interventions. Sleep with the head of your bed elevated 15 to 20 centimeters, not pillows under your head. That creates neck flexion, which actually increases abdominal pressure. Elevate the entire bed frame at the head end using blocks or a wedge under the mattress. This creates a gentle slope where gravity assists the sphincter in keeping contents down. The effect on nighttime reflux is dramatic. Most people experience 60 to 80% reduction in nighttime symptoms within the first week. Do not lie down for 3 hours after eating. Gravity is a significant assist to sphincter function. When you are upright, stomach contents naturally settle at the bottom, away from the sphincter. When you lie flat, contents distribute evenly and pressure against the valve increases. If you eat dinner at 7 p.m., do not lie down before 10 p.m. Dietary modification. Reduce meal size. A stomach distended with large volume creates increased internal pressure that pushes against the sphincter. Eat smaller meals more frequently rather than 3 large meals. This maintains more consistent, lower stomach pressure throughout the day. Eliminate sphincter-relaxing foods for 30 days, then reintroduce one at a time to identify your specific triggers. The primary culprits are chocolate, peppermint, spearmint, coffee, alcohol, carbonated beverages, and high-fat foods which slow stomach emptying and increase pressure duration. Increase protein relative to carbohydrates, particularly refined carbohydrates. Protein stimulates gastrin release, which increases sphincter tone. Carbohydrates, particularly simple sugars, ferment in the stomach, producing gas that increases pressure. A meal of grilled chicken and vegetables creates less reflux than pasta with tomato sauce, even though tomatoes are often blamed. It is not the acid in the tomatoes, it is the carbohydrate load in the pasta. Chew thoroughly. Saliva contains bicarbonate and enzymes that begin digestion in the mouth. The more thoroughly you chew, the more saliva you produce, and the less work your stomach must do. Reduced stomach workload means reduced acid production and reduced contractions, both of which decrease pressure against the sphincter. Physical interventions. Lose abdominal fat if you carry excess weight in your midsection. Every kilogram of abdominal fat lost reduces intra-abdominal pressure and decreases reflux frequency. This is not about appearance. This is about mechanical pressure relief. Wear loose clothing around your waist and abdomen. Tight belts, shapewear, compression garments, all of these increase abdominal pressure and force the sphincter to work harder. If your clothing leaves a mark on your skin, it is tight enough to affect sphincter function. Diaphragmatic breathing exercises strengthen the diaphragm, which supports the esophageal hiatus and helps maintain proper anatomical positioning. Lie on your back, place one hand on your chest and one on your abdomen. Breathe in slowly through your nose, expanding your abdomen while keeping your chest relatively still. Exhale slowly through pursed lips. Perform this for 5 minutes twice daily. Within 2 weeks, you should notice improved symptoms, particularly if you have a small hiatal hernia. Sphincter strengthening exercise. This is not widely taught because it cannot be monetized, but it is remarkably effective. Swallow saliva deliberately 10 times in succession every morning and every evening. This repeated swallowing action exercises the sphincter, increasing its muscular tone through repetitive contraction. It takes 30 seconds. After 3 weeks of daily practice, resting sphincter pressure measurably increases in the majority of people who perform this consistently. Medication taper protocol if you are currently on acid suppressors. Do not stop abruptly. The rebound hyperacidity will convince you that you need the medication permanently, which is exactly what happens to most people who attempt to quit. Use this gradual reduction protocol instead. If you are on a proton pump inhibitor taken once daily, switch to taking it every other day for 2 weeks, then every third day for 2 weeks, then stop completely. If reflux symptoms return during the taper, maintain that dosing interval for an additional week before proceeding to the next reduction. Simultaneously implement all the sphincter strengthening interventions described above. The combination of gradual medication reduction and active sphincter restoration prevents rebound while restoring normal function. If you are on twice daily dosing, reduce to once daily for 2 weeks, then proceed with the every other day protocol described above. The taper should take 6 to 8 weeks total. This is not fast, but it is effective and prevents the rebound that causes most people to give up and resume medication. Now, the timeline for results. Postural changes produce noticeable improvement within 3 to 7 days. You should experience fewer nighttime reflux episodes almost immediately. Dietary modifications show effect within 1 to 2 weeks as your stomach adjusts to smaller meals and elimination of sphincter relaxing substances. differences. Sphincter strengthening exercises require 3 to 4 weeks of consistent practice before measurable tone improvement occurs, but most people notice symptom reduction around week 2. Complete resolution, meaning no symptoms without medication, typically occurs within 8 to 12 weeks of full protocol adherence. This assumes you are addressing all contributing factors, not just one or two. Partial implementation produces partial results. How old are you? Write it in the comments. I want to see which age group makes up the majority of our viewers experiencing reflux, because the prevalence increases significantly after age 40 as sphincter muscle tone naturally decreases with age. Now, the warnings. If you experience any of the following symptoms, this is not simple reflux and you need immediate medical evaluation. Difficulty swallowing, particularly if it is getting progressively worse. Unintentional weight loss of more than 2 kilograms in a month. Vomiting blood or material that looks like coffee grounds. Black tarry stools indicating upper gastrointestinal bleeding. Severe chest pain that radiates to your arm, jaw, or back. These symptoms suggest possible esophageal stricture, Barrett's esophagus, esophageal cancer, or cardiac event. They require emergency evaluation, not home management. If you have been on acid-suppressing medication for more than 5 years, you need endoscopy to evaluate for Barrett's esophagus, a precancerous change in esophageal tissue that develops in approximately 10% of people with chronic reflux. This examination should be performed before you begin tapering medication. The protocol described today addresses functional reflux in people without these complications. If you are taking blood thinners, the dietary changes described may affect medication levels because improved digestion enhances vitamin K absorption, which can reduce anticoagulant effectiveness. Monitor your INR levels if you are on warfarin and implementing this protocol. Work with your prescribing physician to adjust dosing as needed. Subscribe to Dr. Waterling if this information gave you a clear path forward that no gastroenterologist has ever outlined in an appointment. We are building this channel to provide the mechanistic understanding and practical protocols that conventional medicine does not have time or financial incentive to deliver. The system profits when you stay on medication indefinitely. There is no revenue in teaching you that your valve is weak and can be strengthened. Your 15-minute appointment will focus on prescription renewal, not sphincter rehabilitation, but you now have complete understanding of what is actually wrong and exactly how to fix it. Start tonight. Elevate your bed. Eat your last meal 3 hours before lying down. Begin the swallowing exercises tomorrow morning. Eliminate chocolate, coffee, and alcohol for 30 days and observe what happens. Within 2 weeks, you will know whether this mechanical explanation applies to your reflux. And if it does, you will have your answer without a lifetime prescription. If this video helped you understand what has been dismissed as simply too much acid, send it to someone you care about who keeps antacids in every room of their house. You may have just given them the explanation their doctor never provided and the solution that actually addresses the cause.